So these cafes will be, again, we're covering the clinical competency committees today. We will have a portion of this meeting that will be recorded and stored on the ONTPD YouTube site. If you haven't seen that yet, you should check it out, and you will also see the previous virtual cafes that we have hosted. And then about halfway through, we will also turn off the recording and allow more open discussion. So the first part will be kind of this moderated panelist discussion, and then we will move into the section of open discussion. I do have a couple slides so that we can talk briefly about our topic today. So this is clinical competency committees. My name is Melissa Bosserman. I am the Associate Program Director at the University of North Carolina at Chapel Hill, and I'm pleased to be your moderator for today. To review the ACGME program requirements for CCCs, as you may already be aware, clinical competency committees, or CCCs, are a core requirement of our fellowship programs based on the ACGME requirements. The ACGME says that the composition should have at least 3 members, and at least one of those members should be a core faculty member. Other members should be faculty members, either in the same program or other programs, or other professionals with extensive contact and experience with program fellows. They specify that meeting frequency should occur at least semi-annually. And then the purpose of the CCCs per the ACGME is to determine each fellow's progress on achievement of the subspecialty specific milestones. And they should also meet prior to the fellow's semi-annual evaluations and advise the program director regarding each fellow's progress. Today, we have 3 panelists that are joining us to discuss their programs and how they use CCCs. First, we have Dr. Kristen Lehman. She is the PD at Harvard University. Second, we have Dr. Anna Banerjee, who is the program director at Loma Linda University. And then third, we have Marianne Kosek, who's the program director at the University of Mississippi. So at this time, I will invite each of the panelists to talk to us about, give us an idea of their programs. We tried to get programs of different sizes. And if you could tell us a little bit about each of your programs so that different programs can kind of understand your recommendations in context. So let me start with Dr. Kosek, who I should mention is on service, so she might come and go throughout this session.
Well, welcome. I can tell you a little bit about the University of Mississippi, our program and our CCC. We've modified it over the years. Our program started in about 2014, so we've modified this document almost yearly. We kind of tweak it a little bit, but basically to kind of go through some of the things that we have. Well, first of all, our program is small. We've got about 6 fellows, two a year, and our CCC committee. And I don't know if we can show what our document looks like.
Sure.
Our committee is made up of mostly faculty, one of the head nurse for the nurse practitioners, and our coordinators on our committee, and also most are core faculty. But we've got a list. There's 1, 2, 3, 4, 5, 6, 9 or 10. And it just kind of depends, and we do all the CCCs, we do them twice a year, and we do them in about December and then in May. And then it just depends. Most of them are in person. I mean, with virtual things, we did them a little virtually previously, but now they're mostly kind of confidential and in person. And we show the fellows the document for the CCC when they come into the fellowship, and if we've changed anything, we share that with the other fellows, the 2nd, 3rd year fellows. But these are some of the things that we look at are listed on the paper. And we look at their site exam scores. We have the fellows log their procedures and their cases. They log the different types of conferences that they go to. They you know, and a lot of the things that we do is in something called MedHub. And so we can pull before each CCC, the admin can pull the statistics for each fellow. But I like to go over these forms with the fellow, either myself or the APD. We go over these forms that are complete about a week before the actual CCC, so that we can fairly give the fellows credit for something that they may have forgotten to log in, or, you know, we want to let them, I want to let them shine the best that they can for the committee. And, you know, the program directors are not voting members of the committees. I still do go and listen, but I take the feedback really very seriously from my committee, and you know, but anyway, so these are the things that they look at, and it's a really big job, I think, mostly for the coordinator, because she has to compile all this information at least a week before the meeting, because the fellows want to meet with either me or the APD to go over what's on their forms. And throughout the year, they're able to look at their own evaluations online to see what numbers that they're getting rated on for each one of their electives and their subspecialties. So what we do is we have they're all divided by milestones, and we pull the numbers that are in MedHub and on the NICU evaluations. And we have the way we do our NICU evaluations, because sometimes we're only on service for the attending is on for maybe 1 week of the fellows 2 weeks. We as a group evaluate the fellows monthly when we do our faculty meeting, and that way it doesn't take us very long, but we just take the first 15 minutes of the faculty to kind of go over milestones just for that, for the NICU that previous month. And it helps us a lot, because then we capture how the fellows are doing at night on night call, because sometimes the NICU evaluations don't really encompass, if the attending is there during the day, they may not know, kind of get a good feedback or good, are not real accurate on these milestone forms unless they get kind of a group representation from the other faculty that are there at night with the fellows. So after, we also include on the CCC their 360s. So we send evaluations out again through MedHub to all different types of folks, the physical therapists the fellows work with on a regular basis. So we do the physical therapists and the pharmacists and the dietitians and folks, and of course on the 360s their parent evaluation. I think that's kind of toward the bottom, but we add up all the scores, and then when we meet with the CCC goes through all the things on the list, and then we look at what we also have the fellows grade themselves on their milestones for each one of the milestones, and then the group decides what the final number is going to be. So it's usually 0.5 plus or minus whatever the average number is when they average it through on the computer. I don't know if that makes sense, but we put a whole bunch of different things besides just the milestones. We let them, the last part that you were on, right on the very bottom, this is where the admins, the educational coordinators, get a little bit of chance to give their way in on the fellows. And so they get a chance to, kind of help tell if the fellows are reliable about doing their documentation, and whether they have to keep at them to get their documentation complete. And when they go to lectures, the admins get a little chance to weigh in on the fellows semi-annual CCC. And then each fellow has 3 different mentors. They have an academic mentor that kind of helps them with any types of academic things that they have, or their just a person to bounce ideas off of. And it's a different person than just the program director or the APD. It's somebody that they've picked at the beginning of the year of their fellowship that they can kind of they have some camaraderie with. So they have an academic mentor, they have a research mentor, and they have a QI mentor, because each one of the fellows does a QI project. So they meet with their mentors however often it takes. The research mentors more often than QI or academic mentors. Sometimes they don't have to ever meet with the academic mentors because they're never worried about anything. But that's also an evaluation that the fellows do in MedHub, and we can pull that up at the end whenever we want, but we can pull that at the end of every 6 months. They do city training, they do ECMO training, and all those things go on this main page that we look at. And then after we've gone through all the different topics, then the committee makes has some general statements. And the bottom line is they either, recommend that the fellow be advanced or remediate. And then also we've added on this year the SCA approval. So for the moonlighting, we were having a difficult time trying to decide. And I think I emailed Patrick incessantly about what everybody else does was the moonlighting, but we've come up with a system where every 6 months the CCC group is the one that recommends that the fellow can do more moonlighting for the next 6 months or not, and that's based on how they rank them on their at the meeting. So, for example, if the fellow didn't have all their documentation done and they were not doing very well on their site scores, or whatever if there was an issue, then they may say that they recommend the fellow not do any SCA for the next 6 months. So every 6 months they have a chance to, look at it again. And we've never had to really hold anybody's SCA, but to take it away from having the program director be the person that, carries the stick and says no more SCA, it comes from a kind of a neutral body and weighing all the things at once. So that seems to have helped. And then after we do the CCC and we meet with the fellows, usually the chairman of the CCC first meets with the fellows and goes over the numbers, and then they meet with me after that. But we give them a chance during that, not when they're with us with a group, but when they meet with us individually after we're all done, they give a chance to kind of give their perceptions of their training and their electives. And there's a third question on there on the bottom. What are they doing for their lifelong learning? So we just picked those particular questions just to get some feedback from the fellows on the program. And so that kind of helps us build things in to make things better. And we do this twice a year. The fellows know way ahead of time at the beginning of the year. We give them all the deadlines and of the different meetings, so they kind of they know ahead of time when they have to get their logs done and when they need to get all their parent evaluations. And we have gone through the parent evaluations. This is a whole topic, I think, on its own, but we've gone through many ways to try to get the parent evaluations, and we tried the paper things, and the parents wouldn't turn them in, or they would get lost. And one fellow had a stock of parent evaluations in one of the drawers. And so then this year, our educational coordinator revolutionized our life and made QPC codes for their evaluations. So now the parents can just use their phone, and they can it's a roll down bar with all the fellows' names, and their pictures are on there, so they can evaluate the fellows anonymously, and that comes to us directly. So we're trying that this year.
Marianne, that is amazing. And we're all, I think, jealous of your coordinator. We would like to poach them, because that was a phenomenal amount of information to put together. So what a wonderful resource and document that you've shared. Let me switch to Dr. Banerjee. Do you want to tell us a little bit about your program structure and how you structure CCCs?
Thank you for hosting this. It's one of my favorite topics. I know it sounds crazy, but it's such a powerful topic and an important one. Dr. Kosak, thank you for that introduction. You kind of framed it really well for the rest of us. So I just greatly appreciate it. So I loved how Dr. Kosak kind of set the stage, and I love that document. I think what's really cool about having these conversations is we sort of see how we meet the requirements that we have to meet, but also adapt to our individual settings because we all have kind of different pulls and pushes. We have 4 fellows per year, so a total of 12 fellows. Our faculty is quite large for our group. And so we have, just as Dr. Kosak mentioned, really flexed the way we've approached our CCC quite a bit over the last few years. One of the ways that we've approached it is to have a predominant number of core faculty who have really close involvement with the fellows be present. And the reason we've chosen to do it that way is because it sort of takes a little bit of the onus off of how do you share that really important information based on where the fellows actually are. So a lot of what Dr. Kosak was presenting in terms of that CCC document, I absolutely loved it. We get some of that information from our 6-month evals, and I really liked how she framed putting it, sort of on the CCC's shoulders a little bit more, or as a document that can be reviewed. So we have one research faculty member who's typically on the SOC for almost every one of our fellows. And he just provides a different perspective related to professionalism and deadlines that has been really useful, and oftentimes carries that non-clinical perspective that many of the milestones sort of reach and hit. Several of the other members of the CCC are also, as Dr. Kosak was describing, sort of mentors of the fellows. So they have an insight in addition to watching them clinically, kind of what else they might be struggling with, and sort of may have some more insight in creating a plan. One of my challenges when I started learning about the CCC is, how do you schedule a 2-hour meeting and get through 12 fellows? And that's a lot of data. So we, at the time, had the chair, after we went through a couple of meetings that were not particularly time sensitive, we had the chair take a lot of this information that was submitted in advance by multiple sources and sort of assign draft milestones. And the group would then decide, in general, if there were a majority of fellows in particular classes that were roughly doing okay, they would get briefer discussions. And then the focus would be on those that we might have been a little more worried about or needing more attention. So for example, at the November-December meeting, we really chose to focus on the first-year class and making sure that transition had happened smoothly. Had they passed their pediatric boards? Were there other considerations that were making that transition more or less difficult for them? In the June meeting, the May-June meeting, we really chose, of course, to focus on the graduates, but also perhaps to say, are there some, remediation is a strong word, but sort of an action plan that could help us address early problems. One of the things our group struggled with is, is the CCC a group that becomes an authority figure later? Or are we kind of a first warning, early warning system? And I would love to hear the group's discussion on that. I think we have gone both ends of that pendulum and settled somewhere in between at the moment. The other thing I just want to emphasize and just sort of narrate, as Dr. Kosak said beautifully, one of the hardest jobs of being program director is being the bad guy. And I think that harnessing the power of the CCC so that you have a group of people who are very invested and very knowledgeable about the requirements of the program and about what it means to advance means that you can harness the power there if there are challenges or things that need to happen. So what I mean by that is I have interfaced with our internal medicine program director, our PICU program director, and several others within our community in other states. And particularly when you're dealing with fellows that are challenged by different things, be it a leave of absence, be it something that has affected their ability to continue on their path. Addressing specific behaviors or ways to continue that path How do you address rejoining training? How do you address a transition plan? Those are things that the CCC can really do, and for us have done in those interim meetings. We've actually met almost quarterly just because it's come up a little bit more for us during the pandemic. And that has been really, really much more powerful for us, and taken a little pressure off of me as well. One of the questions I would love to pose to the group in general is how you address the transfer of information. We do have, for example, all the information that Dr. Kosek described, but how do we, typically it's the APDs and the PDs who know it best, and ideally their voices are a little more quiet at those CCC meetings. So how do we kind of allow the rest of the committee to learn that information so they can intelligently assign milestones and move forward? So I don't know if that starts it. I didn't touch Dr. Kosek's presentation, but just a quick introduction.
That was great. We're going to allow, I've written down your questions so that we can pose them to the group, but I was going to turn to Dr. Lehman so that she can introduce her program and kind of her approach or structure for CCCs.
Sure. Hi. So I'm Christy Lehman. I'm the program director at the Harvard Fellowship. We have 18 fellows, 6 fellows a year. So we're a large program. We have 74 faculty members, and we have 9 faculty members on the CCC, and 1 nurse on the CCC. So we have 4 hospitals that our fellows rotate through. So there's representation from each of the hospitals. And like I said, it's really been very valuable to also have a senior nurse on the CCC that sometimes has unique perspective and input. We meet twice a year. We split up the packets of evaluations amongst our 9 CCC members. So each faculty member has, each CCC member has 2 or 3 entire packets that they go through that include in-service, attendance, procedures, and then all faculty evaluations, all 360 evaluations, and a self-evaluation. We incorporate 360s. We have really good return on them. So we have, bedside nurse, RTs, NNPs or APPs, families. How we distribute those is the attendings on service, distribute them halfway through rotations, and they are either collected or they can also be mailed. They have and we have drop boxes for staff and family members. So we incorporate all of those in the evaluations, and then each CCC member presents those 2 or 3 fellows to the group, and we have, discussion and input from everybody who's worked with them. Then the other things were, I think it's really been super valuable to have the nurse presence, I'll say, because I think she's one of the charge nurses that works very closely with the fellows on medical control and things like that. And so has very valuable input that has led to a lot of constructive opportunities for conversations and things that we might not have been able to uncover and help with if we hadn't had her input. And then we review all the CCC information with our CPCs when as the program director, I meet with them twice a year. So we really focus on just the clinical performance during the CCCs, and we have a whole separate research, scholarly, SOC management and group and whole infrastructure for that. So this is really just focused on their clinical performance and milestones.
That is excellent. One other question. I know that many of you have been program directors for, or at least involved in program leadership for a while. What is one thing that you have evolved in your CCC process over time, and why? So I'll give an example. I know another program I was talking to said that they incorporated APPs over time because that gave valuable input. And I've heard another program say that they actually stopped including APPs in their program because it ended up being more of a negative relationship is how that kind of evolved in their program. So what are something that you have learned? What's a lesson that you have learned in yours? How have you modified or your CCC over time to fit the needs of your program, and why?
I can start. So one thing that we've modified with our CCCs over time is really, ensuring that there is ample opportunity for each of the fellows to, display their, incorporation of cost awareness in like their management, or some of the things that might not be as clearly obvious for the evaluators as they're doing their evaluations. So a couple of the opportunities to have prompts on the evaluations for specific examples, and then set up, one of the presentations they give is about cost and, value, really. It's really about value, but, to really ensure that the clinical experience allows each of the elements that you're evaluating opportunity for them to show their promise in that area. So for patient care and things like that, it's obvious, but some of the elements you might not have the opportunity to give an effective evaluation on. So we've added things like, for example, cost, making sure there's observed education of families and patients, trainees, which is probably happening on rounds, but really making sure that people in their written evaluation discuss several of those things so we can assess progress and growth in those areas.
Dr. Banerjee?
I liked all these responses. I'm taking notes myself personally. I think that one of the things that we had been working on was just with the size of our group, and I know it's come up in many of our recent meetings, a lot of generational changes and differences in training in terms of the experiences that residents are coming into fellowship with or without compared to the past. So just speaking very specifically, we had noticed in the last couple of years that a couple of our trainees were, perhaps not where we had hoped they would reach with regard to, reaching graduation and being deemed competent. So it was actually the CCC who came up with a recommendation for some specific oral cases that would help this person kind of reach that particular milestone. Except on hindsight, they said, gosh, even though it's being developed for one particular trainee, it turns out that all of them might benefit from it. So what, as a recommendation from the CCC, we had a group of very invested faculty develop cases that were kind of meant to be kind of a bread and butter case, and then it had different levels of board relevant material on it, be it an equation for oxygen content, or how would you consider diagnosis or management at this fork in the road? And then it was kind of vetted by several other faculty members. And then we would do them in pairs. And each one kind of had a little suggestion for a Neo Reviews article or another pertinent article that was very accessible and very general. So as it turned out, although there was a lot of fear going into it, and initially it kind of came out of a discussion for one trainee, it actually got great feedback from the entire class after they went through it. And it even allowed the faculty to say, gosh, you handle it that way. That's interesting. I handle it this way. So some of those things that we think are very common, maybe somewhat, disparate. So it just took our training to a different level on some level. So I know that's not directly something that we had evolved, but it was another great finding that came out of just CCC discussions about training and trying to get our trainees to where we want them to be.
That's great. Dr. Kosek? You could unmute.
I think for us, almost every CCC, something comes up that we say, oh, we should do something different in the program, and it gets kind of escalated to the next PEC meeting when we make some changes in the program. And I think probably one of the things that we've done recently is just those evaluations for night call. And I mean, we talk about people getting burned out from doing so many evaluations on the fellows. It's hard. It's like herding cats to get people to evaluate anybody. But especially at night, we were originally, we had these evaluations that people would get randomly on evaluating a fellow on call that night. And through the CCC, when we realized that just wasn't working out very well to get any information that was helpful, that's when we decided to make all the evaluations as a group once a month.
That is really great. I'm going to ask a couple just rapid fire questions to the panelists before we open it up to everyone. So first, actually, why don't we have all of the participants can answer this. You can raise your hand or put a thumbs up if this applies to you. So which groups use 360 evaluations as part of their CCC? Yeah, and the crowd can do that as well. I'll put my thumbs up. Yeah, it looks like there is, I think some thumbs are going up, but it looks like maybe around half, a bit more than half of the people, if everyone's participating. And then the next question is, do you have your faculty complete milestones prior to the CCC? Do the faculty do the milestones, or do you as a CCC do the milestones? And I mean individual faculty versus the CCC. So if you put your thumbs up if you have each of your faculty do individual milestones. I have, okay, I'm getting fewer that say yes to that. And then the last question are, do you incorporate non-MD faculty on your CCCs? So this would include APPs or nurses, as Dr. Lehman does. Excellent. Okay, great. Those are all the prepared questions. I think we have time for 1 or 2 questions from the audience, and then we'll turn off the camera. We'll stop the recording and do some free discussion. Does anyone have a question that they would like to ask all of the panelists? Or any one panelist?
Hi, I'm not going to share. I'm kind of COVID right now, but so thank you for all the information. This is amazing. My question is, so my fellows, I have 12 fellows, they circulate with 3 different sites. How do you make that transition easier to get all the different evaluations and 360s and, you know, when I'm not visiting the 3 sites?
Yeah, I can start with that. So we have 4 sites. So we have definitely felt the kind of logistical challenges of having evaluations at all the sites. So our faculty evaluations that are rotation based go through New Innovations, which maybe some of you guys use for evaluations, but they're assigned. Yeah. So that helps because that's assigned, and then we send reminders and follow-ups and just like get after people to make sure that they do it. We've also recommended that it's a physician performance metric. You know, each of the 4 sites, some do that, some don't, but you know, like they're to be a faculty at a teaching hospital and to have a physician performance metric of like, I've filled out 100% of my fellow evaluations is something to consider as for leadership. The other thing, the more kind of handwritten evaluations, which I know you guys are using QR codes, which is cool. We have boxes, we have drop boxes at each of the sites that are in the attending call rooms and then at the rounding workrooms that they're locked, so they're anonymous, and our coordinator or the coordinator at each site will periodically check those and scan them and send them to our coordinator. And then we also have the ability to mail them. So some families choose to mail them, so they have an envelope, and sometimes they come in the mail. Mostly that's families, not staff.
How would you distribute that to patient families?
So we have struggled with that. We've done different things. The thing that we're doing now, which seems to be working well, is that we halfway through a rotation, we send like 3 family, we say distribute this to 3 families that the fellows worked with closely, 3 nurses, whatever, I forget all the numbers, but however many there are, we send them out, and then the attending takes the responsibility to print them and distribute them. So the attending on service that's supervising receives
Okay.
them via email and they print them. So that does require a step there, but we've tried all different things like having them on site and reminding them to go get them. But somehow when you get that email, that seems to be, and you know, they copy me on there and I say thanks and kind of send a reminder kind of with a reply to make sure it kind of shows up twice in their emails. And that has been pretty successful.
Great. Thank you so much. I appreciate it.
Other questions? Dr. Kosick, I've gotten some questions in the chat that people would love a copy of the document. Is that okay if I share that? You'll have to unmute, but I think I took your nodding to mean.
Yes, people have helped me over the years, and anything that I have, I don't know if y'all know Dr. Savage, Renata Savage. She was she came when I first became program director, and I took every wealth of bit of information that she had as a program director, and she helped me. So if that is good for y'all, just have at it.
Excellent.
If people want the QR code method of doing parent surveys, and know that the ONTPC, the program coordinators group, has shared that widely among themselves, but I know that not all the program coordinators are hooked into that organization. So please reach out to me and I can have Meredith, who's the CHOP PC and chair of that group, send it out to us more widely.
Hey, well, why don't we end this portion of the moderated chat? I think that we have some good questions that we can go that were posed earlier that we could talk about kind of